Way more nice. And nope, go ahead. I know I gotta show them
Please. I'm going to be the gentleman here.
Okay, keep it honest.
I'm gonna wait for Stan for a second.
I'm sorry.
Find water. Where do you put Stan? You want to grab water. Stephanie, you're fine. Okay. Yeah, we had a couple already. Good evening, everyone, and thank you for coming. As you noticed, do I need the mic? I hate mics. I'm not a fan. Yeah. Well, let's see. Can I take it down from this? Or? You know what? I'm going to use this one. Yes, much better. Thank you so much. For the tall people like me, it's much better. So, good evening and welcome to this panel on breaking silos across disciplines. It's everybody in the room, I think, knows me, but for those online, my name is Hala Madanat. I'm the director of the School of Public Health here at San Diego State, and we, as you can see, with a little bit of rain in San Diego, nobody turns up. We like to stay in. It rains, so we hide. We're not used to it. But we know that we have our live streaming going on, and we are also recording for our students as it nears the end of the semester. They also hide, so for other reasons. But I wanted to take the time to thank our wonderful panelists who took out of their time to be here with us today. And I'm going to do a quick introduction of all of them and then turn it over to Sarah, who is our Graduate Student Council Treasurer, who will be moderating today's session. So for the introduction, first we have with us Dean Donna Peterson. She is the Dean of the College of Public Health at University of South Florida. Next is Dean Boris Lushniak, who's Dean of the School of Public Health at University of Maryland College Park. Followed by Dean Wayne Giles, who is Dean of the School of Public Health at University of Illinois Chicago. And I'm assuming everybody else knows our wonderful Nick Machione, our Director of the Health and Human Services Agency, who I personally added to this panel because, as many of you might know, San Diego is really a model for an integrated agency that brings together multiple disciplines. We're the largest in the nation, and in its own right, will have a huge impact on our conversation tonight in how to do this in an applied setting. And last but not least, Stan Vermont, who's Dean of the School of Public Health at Yale. So thank you so much to all of you for being here with us tonight. And I'll turn it over to Sarah.
Good evening, everyone. Thank you, Dr. Madanat, for that wonderful introduction and for your efforts to coordinate this one-of-a-kind event. As Dr. Madanat mentioned, my name is Sarah Norwood, and I am the treasurer of the School of Public Health's Graduate Student Council and your moderator for this evening. My sincere thanks to Dr. Madanat and to Dr. Eric Walsh-Buhai, who is also in our audience, for the opportunity to do so. Tonight, as we welcome the perspectives of the esteemed individuals before us, we ask that you please adhere to a few housekeeping rules here in the room. You will note that KPBS is live streaming this event, and as such, we ask that you please silence all phones and take any conversations outside the room. In addition, given the event is being streamed, for those in the room, please be mindful of the locations of the cameras if you happen to exit the room for any reason. We thank you in advance for your cooperation with these requests. As Dr. Madanat mentioned, our topic for the evening is breaking silos across disciplines to impact health equality. We asked the faculty and students of the SDSU School of Public Health to provide their questions in advance, so I'm going to kick us off with those, but we will also welcome questions from those in the room later, as well as those who are live streaming. So please stay tuned, and we will open up the floor shortly. So all that being said, I will actually be directing questions to each dean, but please know that you all have a chance to chime in after the initial respondent is finished giving their perspective. So first and foremost, Dean Donna Peterson, you have been a leader in the field addressing the specific issue of breaking silos. Why have you been such a strong proponent of this approach?
It's a pleasure to be here. Thank you, Sarah. Thank you, Dean Modnott. Thank you, panelists, and thanks to those of you who've been in the audience. I've been in public health for many years and was trained in a very interdisciplinary open environment and worked in public health where I recognized early on that you have to optimize your relationships, optimize your opportunities, find people who have resources and talents and skills that you don't, and bring all that to bear to solve the problems that are so important to us. And when I went back to an academic environment, it struck me that we were organized, and I'm still not entirely sure why, often in departments around our particular areas of inquiry, which makes some sense. But when you go to approach the work that needs to be done, no one group of us has a monopoly on all of the answers and all of the tools. And so how do you promote that kind of inner cross-professional approach? And I'm sure many of my colleagues were more successful than I ever was, but I finally decided at the University of South Florida, where I've been for 15 years, after 3 years of conversation, to remove the department structure from within the college. So we are now a college of public health with public health people. We are loosely organized in strategic areas, but no one group that had been in a department stayed together when we split this up. They all moved to different strategic areas. And it's been about 7 months now, and what I have found is a great deal more people coming together across the disciplines. People that knew each other, but for some reason felt that these walls, even though they weren't real, kept them from working together. And we're seeing them reach out in interdisciplinary ways to the community in new ways. Again, the community's always been there. We've known what their issues are, but they're now reaching out and engaging with them in new ways. And I'm also watching them reach out and engage across the campus in new ways. So we suddenly have new partnerships with our School of Architecture and Urban Planning and our College of Marine Science and the Business Entrepreneurship Center. And I could go on, but to me, it all boils down to what the essence of public health is, and the importance of our work, and the commitment that we must make to the work that we do. And it takes teams, multidisciplinary, multi-perspective teams, and as leaders, we have to do everything we can to create those opportunities for people to come together across those perspectives to do the work that we need to do.
Mm-hmm. Would any of our other panel members like to comment as well?
Sure, I'll give it a stab. I'm Sten Vermund. I am at Yale University, and that's one of the big advantages of our school of public health, is that we're within a university with immense talent, and we try to open up our opportunities for our students to go far beyond public health. So our health management and health policy students are not uncommonly in our School of Management. Folks interested in social justice are not uncommonly finding their way to our law school and our divinity school. Our health, folks interested in health reform and the inefficiencies of the American health system are linking up with like-minded folks in our Department of Economics and the Tobin Center for Economic Policy. And I could go on. And I think that is a huge advantage of places like San Diego State University, where you have your School of Public Health nested within a very substantial university, and the resources that are available within the school are substantial, but the resources outside the school, right on your doorstep, are really immensely appealing. We've been getting out of the box lately. We have a new initiative with our School of Architecture around health and the built environment. You can build buildings that are healthy and buildings that are sick, and you can build buildings that foster a sense of wellness and buildings that depress you. and we're working with our School of Music in some initiatives around wellness and healthy aging, trying to take advantage of strengths at the institution that are not in the silo of public health per se, but with a little bit of imagination, are really immensely relevant and inspiring for our students.
Absolutely.
It is interesting. Boris Lushniak from the University of Maryland, College Park. You know, when you look, my favorite definition of public health comes from C.A. Winslow, right? It's one that's cited. You know, I know everybody else has their favorite. This one's my favorite. And what Winslow said back in 1920, and mind you, he's a microbiologist by training, right? So he comes at it from Yale.
Founding dean.
But he talks about, as I describe to my students, the 3 Ps of public health. It's about promoting health and wellness. It's about preventing disease, I'll add injury, preventable deaths, with the goal of prolonging, and I'll add a high quality of life. But the second part of his definition is just as critical, because in the second part of the definition, if you look it up, C.A. Winslow, 1920, it'll talk about the partnerships that need to be established to achieve that. So this concept of interdisciplinary is actually not novel. He talks about organizations, both private and public. He talks about, yes, government playing a role. He talks about individuals, right? Society playing a role in all that. And I really look back that this is 100 years ago soon, that we already knew we needed these partnerships. But I would agree. I think our concept, a microbiologist said this and said it takes more. But what we've gotten better at over the years is more has become even more. And I'll tell you, we talk about the built environment. That's, I think, my most exciting revelation, right? For 5 years, I had the honor of serving as the Deputy Surgeon General of the United States, a year and a half as the acting U.S. Surgeon General. And I remember once I was, all they do is run you around. You have a nice uniform, right? You look good, right? There's medals, and you talk public health. And I can speak public health, but I remember one time when we were pushing the national prevention strategy where they took me and said, okay, you have a gig now, right? And it was in front of the American Institute of Architects in D.C. And I remember sort of coming in there. I'm a CDC trained, EIS officer. I thought I had seen partnerships, but I'm talking in front of a bunch of architects. And I'm like, well, this is kind of interesting. And then I had this aha moment that got substantiated 3 days later, because then I'm speaking in front of the American Planning Association, 5,000 strong. And it was down, I think, in Orlando, their annual meeting, and it was such a kick to actually talk public health to a group that was just sucking it up. And I realized we can't do this alone, right? When we start talking to the architects and the city planners and all that, that's a sign, first of all, of the boldness of our mission in public health. We rock. We can change the world, but we can only do that with those partnerships.
I want to flip it a little bit, and I want you to think about the communities and the communities that we are interacting with on a daily basis. Because I think when you think about the issues that they are struggling with, right, if you can think about the health issues, but you also need to think about sort of what underlies those issues, right? It's education, it's economic development, it's employment, right? So how do you need to be developing those relationships, right? It's urban planning, it's how our cities and communities are designed. All of that's part of it. And so really, if we're going to be effective, if we're going to have impact, we've got to get to sort of what are the root causes that are impacting our communities. And that, to me, is part of why this interdisciplinary approach is so important, because of what's happening in our communities. And I think we need to keep people in our communities at the center of everything we do. And that's where we need to focus.
Okay. All right. Thank you so much, folks. Moving right along, Dean Boris Lushniak, what barriers do you see remaining for academic public health to train the next generation of public health professionals to think about health equity in a more integrated manner?
Well, I think the barriers are, first of all, it's the difficult path we're on regarding health equity. First of all, it's the subject matter itself. We all have programs in health equity. We talk about it. It's the idea of how do we actually implement it. And the question really goes into this idea that we can't do this alone. So I think part of the idea is, first of all, to define it appropriately. What are we trying to achieve through health equity? Secondly is, who are the partners that need to be there? I think those are barriers that we need to not only teach our students, but in essence begin understanding that our students have a different view of the world than we did. And in essence, as an educator, to listen to our students and say, okay, you understand the difficulties that we're trying to achieve here in terms of substantiating a society that we have this health equity implemented. Do it, right? Part of the barrier is that we're just learning as we're getting through this, right? I mean, we've gotten better at it over the years, but we haven't come up with the answers. My other favorite definition that I like using, and that I keep saying when I speak about this, these are things that are on my wall, on my office throughout my whole public health career, right? One is the C.A. Winslow definition. The second are the top 10 public health achievements of the 20th century that remind me, and health equity is not listed on there, right? The concept in those 10 achievements are vaccinations, motor vehicle safety. But I dare say that we are priming ourselves up that in this century, we need to make sure health equity is on there. The third definition that's on my wall is the World Health Organization definition of health, which I'll remind you is aspirational because it starts out with an important adjective. It's complete, not partial, not halfway there. It's complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So when you combine that whole concept of health equity and realize that that definition is aspirational, the barriers in front of us are, yes, support, and here we talk about the dearth of funding for public health equity programs throughout our whole nation, throughout the world. We have to have an interested student body who become the next generations of leaders on this, right? And it's, in essence, using 21st century tactics in that approach, which is understanding, for example, the world of information technology and how it applies to the world of health communication, health literacy, and ultimately trying to make way in terms of health equity.
Of course.
So you asked what are the
barriers.
Yeah, so when I think about the barriers in an academic environment, I think a lot of what we know we want to do, what our students are compelling us to do, we're hampered by these structures, these sort of fossilized, concretized rules, and the students have to pay this much money, that's number one, for this many minutes of instruction in these kinds of classrooms with these kinds of assessments and these kinds of products and these kinds of outcomes, and there's reasons why all those things exist. Part of our challenge is how to get over them, meet the standard, no one's trying to not do that. But our students will tell us, we want to be out in the community learning, to your point. Why am I sitting here? And we had someone from Maryland come and speak to us years ago and said, if they can find it online doing a search, you shouldn't be wasting time talking about it. So how we even engage students in a learning process that is much more self-directed, community-based, service learning, all those words we use. It's challenging within the rule structure. It's also challenging within the faculty, quite frankly, a lot of whom are not comfortable with that, don't know how to do that. And if we don't have good relationships with our community partners, I'm looking at Nick, then that's a hurdle that then you have to invest in it somehow, because then you have to have manpower that helps fuel that engine so that it's not a burden to our community partner, but it is in fact helpful to our community partner. So I think there's a lot we know we need to do, and getting into the community forces you to face things like housing and transportation and the racism that exists that undergirds a lot of this. And how do you tackle those things? You're not going to tackle them sitting in a classroom.
I think the other issue is how funding comes.
That's why I started with the book.
Yeah, right. I mean, and I think that's a huge part of this. And so when I was I've been at UAC for 2 years. Prior to that, I was at the CDC, and we did a program actually it's turning 20 this year, called REACH, Racial and Ethnic Approaches to Community Health, but was a community demonstration project that was started under Dr. Satcher. But we had 5 diseases. So it was heart disease and stroke, diabetes, maternal and child health, immunization, and HIV. But I got to tell you, the communities didn't want to focus on just those diseases, right? They wanted to be talking about issues around mental health, for example. Couldn't do that. They wanted to be talking about violence. Couldn't do that. And so that hampered us. The other issue that, to me, as we're talking about issues around health equity, is trust. And many of our communities are deeply frustrated because we come into the community, we do our assessment, we do our survey, the funding ends, and we walk away. And so we've got to be thinking, I like to say, instead of the community trusting us, what can we do as academic institutions so that we are trustworthy? And so again, what do we do so that we have relationships with those communities that are ongoing? And that's hard given the funding, but we've got to figure out models where we can do that, where we can break down those silos so that our communities feel that we, in fact, are trustworthy institutions.
Sir. So, I'm taking this in because this is a great panel, and I was just reminded a few years ago talking to a dean of School of Public Health, none of the prestigious group here. And we talked about what does health equity mean to me? And I said, well, to me it means things like fairness and justice and opportunity. And we have to achieve those things to achieve health equity. And I took it a step further and I said, and in public health, we sometimes have our own constraints because we have fidelity to our profession, because we think everything is solved with the 10 essential functions of public health, when in fact you have to use social architecture. Well, that's when the lunch started taking a turn. Because, you see, that was what I was talking about, was what Donna was hitting on initially. The structural discriminations of what we do to ourselves puts those constraints right from the get-go. If you are not open to talking to, for example, within social services or in terms of political science or those that are going into criminal justice and so forth, we're doing injustice to our employees. Because to deal with the issue of fairness and justice and opportunity is where health meets safety. And that goes beyond the 10 essential functions of public health. And so what I'm really enjoying hearing is that we're now seeing the bigger picture around breaking down those structural barriers that are one of the culprits, not just within schools of public health, but then within agencies like mine, for Health and Human Service Agency, where just a few years ago we added housing. So we're health, housing, and human services, beginning to see the whole person. And when you do that, you move from fidelity to the profession to fidelity to the cause. And the cause is wellness, well-being. And then it's not the badge of honor that we're from public health. It's, yes, we have a command and a capability of doing the type of planning and understanding and evaluation, but it goes beyond us. And so as the conveners that we do exceptionally well in public health, we have to bring the others in that social architecture to really get at the heart of health equity. And that's the journey that San Diego has been taking on for the last 10 years for something called Live Well San Diego. How do you bring, now Donna, we're up to 440, how do you bring 440 partners that you're not paying at all to come to work together and collaborate on the issue of health, around safety, and around economic inclusiveness? And that, I think, is the journey we're all talking about here to get really at the heart of health equity.
Absolutely. Collaboration needed at all levels in all different areas that you've mentioned. Thank you for that. Anyone else?
So just a quick comment about the health director. His observation on structural issues is really quite central, because if you look at the Organization for Economic Cooperation and Development, the OECD, those are 32 or so of the wealthier countries in the world, many of them in Western Europe and North America. One aggregate health index that I saw recently ranked us 31 out of 32 countries in health outcomes between Slovenia, and Slovakia. And yet, we are spending about 18% of our gross national product on health. The next highest is Switzerland at 14%. And most of our comparable countries in the wealthier countries of Europe and Canada, Australia, are spending between 8 and 12%. So we're paying about double to get worse outcomes. And a big part of that is exactly what Nick said about the structural barriers that we've set up for ourselves. I sometimes argue with people we shouldn't even call it the American healthcare system, because it's not a system. It's a concatenation of historical accidents that have been patchwork quilted together by various congressional insights. So you have Medicaid for the poor, Medicare for the elderly, you have the ACA for the working poor, you have the Veterans Administration, which is the socialized system, but just for veterans. And then you have a private insurance scheme where $1 in every 3 is siphoned off just for administrative expenses. You couldn't ask for a less efficient system, and the outcome data suggest you couldn't ask for a less effective system. And the irony is that many European nations with single-payer systems have improved their efficiency and their effectiveness. So better health outcomes for less cost. And I'm hoping someday that the American business community wakes up and smells the coffee and demands more efficiency from their health investments. And the American taxpayer as well, because the way we're going now, we will be at 19% of gross national product within probably a year and a half. By some statistics, we're already there. And we'll be at 20%. So we'll be in one of $5 would go into the health system, just about double what our sister countries are spending. And if we had substantially improved health, that'd be one thing. But in 1980, there was a 1 year of life expectancy difference between us and our comparable European counterparts. Now there are 4 years of difference. So we've fallen 3 years behind as time has gone on the last 30 years, 35 years. So I would say these structural issues must be addressed, or we will continue to waste money and get worse outcomes.
I'll just add that I think it's Elizabeth Bradley's work
Yeah.
in your fine
Yeah.
institution that has...
There's Yale again. I can't help it.
We have brought her together with a group that I serve on, the Milbank Memorial Fund, and the Reforming States groups, that's looking at Senate and Assembly leaders in the House, and as well as secretaries of Health and Human Services, to really have these conversations the last 2 years around how we rebalance our public health, healthcare, and social services. And I will tell you that some states are, Maryland, places like California, Governor Newsom's already doing that, talking about folding in a structural barrier in terms of juvenile justice and bringing that under public health. Taking a more restorative health approach than the more penal approach. So I think there's exciting work happening across states that are beginning to see this frame.
All right. Thank you all for that. Our next question is for Dean Sten Vermoodt. What are some of the ways... Oh, I think this one's for you, Dr. Vermoodt.
Oops.
Sorry. What are some of the ways you see or would like to see technological advancements help impact health equity?
Certainly, we find ourselves in an era of improved technologies. The cell phone here has probably 100 times the computing capacity than the Apollo space flights did to get us to the moon. And I didn't make that statistic up. That's about right. And we've all seen the clips of the big Houston Space Flight Center with all the computers and a tiny fraction of the capacity we have. So the ability to gain information the ability to use sort of electronic health, so-called e-health strategies, improving people's ability to know where to seek health care, know when to take their medicines, be reminded of when to take their medicines, securing resources that they need. The flip side of this technological revolution, and I'm just using the cell phone to represent a wide swath of technological advances, the flip side is also excellent for misinformation. And the state of California, along with the state of New York and many other parts of our country, are facing the worst measles outbreak we've had in decades. The anti-vax movement is growing strong, not merely here, but overseas. So one can communicate ideas that are completely without scientific merit, and we even see that promulgated by some of our senior political leaders in the United States. So we have an immense challenge in health communications that modern technologies can aid or can inhibit. And I think our need to be effective communicators and to be concentrating more on passing on knowledge to lay populations, and perhaps not being quite obsessed about communicating to our peer populations. I know that many of us, myself included, are experts at communicating to people who work in the field of public health. So I'll publish the peer-reviewed article, and it will have some benefit to people working in my field. That's not going to translate necessarily into the broader public. So I think the technological challenges that we face in communications can be a double-edged sword, and it's going to be incumbent on us to improve our ability to communicate effectively complex medical, public health, preventive arguments to lay audiences, knowing that we're up against a technological world where those miscommunications are equally easy to access.
Absolutely.
Let me this, let's face it, this is a game changer, right? And there are issues in terms of this getting bad information or being the seed of bad information. There are issues of this in the world of cybersecurity and personal information and the whole idea of being vulnerable because of this. But this makes, I think, 21st century public health very exciting, because it's things like this, it's the fact that these things begin talking to each other. And the question really focused on the idea of health equity, which is how do you start making things accessible? And the reality is that, you look almost globally nowadays, right? And this is all over the world. Right? We still, don't have full penetration, high speed, this and 4G, 5G all through the United States. But this is going to happen, right? That this will be in everyone's hands as it almost is now. At the end of the day, the question is, how do you use this in this 21st century world of public health for good? How do we make it effective and efficient? Because this also comes with information overload, which then begins to confuse the world as well, right? So this tells me every so often, Boris, breathe. And I realize I'm breathing all the time, but it'll vibrate. It'll say breathe, which means breathe deeply. It's mental health, right? It'll say, Boris, time to stand up, right? And so if I'm really following it, it'll tell me to do something good for my physical health, right? What it's not been doing very well on is on the social health aspect, but maybe that'll help as well. But what I'm really excited about, and I have, my School of Public Health is on an undergraduate campus, kind of like this, right? And we have a lot of undergraduates in the School of Public Health. And I kind of look at that generation where, in the IT world, let's face it, we have a certain generation they always liken this to sort of learning a foreign language, right? This is a learned language for us. We're never going to be fluent in this language. The kids in grade school and middle school now are fluent. This is their first language, and that's the generation I'm counting on. Yes, my undergraduates as well, but they've been sort of in the transition phase. So this is exciting. This is what, in the right hands with the right thought processes, and there is danger, but I think this can really be the life changer.
So I'm going to go back a little bit to the late 70s, early 80s, when mammography occurred, when we started instituting mammography. And before that, there was essentially no difference in breast cancer mortality between black and white women. And then mammography started getting instituted. And it was unequally instituted. So white women had much more uptake than African American women. That's when the disparity started. And I bring it up because as we think about technology, we need to be thinking about equity in terms of access to that technology, right? You look at my watch, and you look at Boris's watch. They're very different, right? But we need to make sure that as we're implementing and disseminating new technology, it is accessible to all communities. Because if we don't do that, we're going to exacerbate the disparity. Mm-hmm. And so that's part of the double edge that we have here. And frequently we don't think about that. We also need to think about who we are training to develop those new technologies. And are those individuals from different communities? Because when they're not, we have problems. I was at the ASPPH meeting a couple of weeks ago. Someone was talking about autonomous vehicles and the fact that they are less likely to recognize African Americans on the street, right? What does that say? It's because who is in the room designing? And so as we're developing the next generation, we need to be thinking about who is in the room as we design this new technology.
Maybe just one additional comment. The potential for diagnostics, speaking to our medical colleagues, is absolutely vast. I've seen cell phone technologies being used for diagnosing dermatologic conditions with photonic techniques. There are now cell phone apps that turn them into ultrasound machines for pregnancy diagnosis. There are apps that can diagnose retinal imaging, telemedicine to get insights into cardiovascular status. You can use it as an ECG, an EEG. It goes on and on and on. So I do think that if we can overcome some of the systemic issues that Wayne has highlighted for technologies actually exacerbating health inequities in both the U.S. and the global context, there is the potential for democratization of access because of reduced costs and machines that might have cost $3,000, which is not uncommon for an ultrasound machine, can be dropped down to $100, and people are talking about dropping it down to $30. So the notion of these being available to rural physicians in the U.S., not to mention rural physicians in Africa, now become very exciting.
Yes, lots of interesting technological changes happening that are helping facilitate too that move from the inpatient to outpatient focus. So there'll be quite a few challenges ahead, it sounds like, for our generations and the ones that come after us. All right, the next one is for Dean Wayne Giles. As early careerists, how could we position ourselves to break down existing silos in our place of work? As the new person, how could we tackle an environment that is still siloed?
So a couple of things first. I think one is I would go back to what I started with initially about sort of thinking about the individual or the community. And I think about, for example, my father, who had arthritis, diabetes, heart disease, and you name it. So, thinking about sort of part of what we need to think about is sort of as we are training the next generation is them being equipped to tackle those issues that people like my father are dealing with. And so I think that's part of this. And so as we're thinking about the curriculum that we're giving in public health, I think thinking about sort of how we can integrate that curriculum is vitally important so that our students and the next generation of public health leaders can get that broader training, that broader education that I think is part of this as well. I think the move in healthcare to team-based care really sort of helps to facilitate that work, and sort of the work that we are doing and all of us around interprofessional education, I think provides that very cross-cutting education that we need for the next generation of young people as well. So I think all of that is part of sort of how do we create opportunities for young people to address these challenges as part of all of that team-based work that I think needs to happen. Other comments?
So Wayne is right, and as new people going out, assuming you're exquisitely trained here, I assume you are, and all of us are really working on these interprofessional opportunities and work cross disciplines. But you're going to go out into an environment that still suffers from the structural barriers we're talking about and old ways of thinking, and it's very, very hard. And so I think part of our job as academics is to equip you with the fortitude and the stamina and build the network now, because you're going to have someone to go back to give you the strength you need, because we're counting on you to change the world. We're trying to give you the skills. We're trying to anticipate the future and know what you're going to face out there. I'm continually frustrated at when I hear from students who say, yeah, everything you taught me, I don't disagree, but boy, no one wants to hear it out there. Maybe in the San Diego County Department of Health and Human Services, you would have an open ear.
Housing.
But I also think it's part of, we're all kind of saying the same things, but, how do you have sort of an open mind, open ears? How are we listening for what our communities are really telling us they actually need, rather than here's what we have to give you. I loved your story. Well, we're here and we can work on all these diseases. People say, I don't want to work on diseases. I want to work on the quality of life in this community. I had an experience when I was in graduate school very much like this, where we had some money and we decided to devote it to something, but we had to do it secretly, which I always tell my students, never let anyone tell you, don't ever do that, but we did it. And went out to the community after it was announced, because I had enough brain cells to know that I better get out there immediately to say, hey, I know this was just announced, but we really want your input, ouch. And we had this after-school program. We're really proud of it. And what they wanted to talk about was rats in the neighborhood. And it got so bad that the mayor had to go to this community to calm them down. And live on 5 o'clock news, I was home. I was a brand new master's grad. You have to understand this context. I'm watching him live on the news, and a huge Norway rat, if you've ever seen them, they're awful, ran right in front of him. And he said on live TV, holy shit, did you see the size of that thing? I thought, my career is over, my public health career, classic mistake, because we see things, here's what's in our toolbox, let's go apply these things. And we never asked the community what they actually cared about. And they actually talked about a health thing. They could have talked about something that wasn't even directly related to health, the way we tend to think about it. But really, you need to think about the fact that everything is directly related to health, and anything they bring to your attention has to be of interest to you and of concern. And it gets back to why you have to have partnerships, because you can't go out there and do an assessment of health needs and people are going to raise things like the quality of their school systems or the crime and say, oh, well, I don't do that. You can't do that. That's not an ethical thing to do. So you better have someone to call when you go back to the office to say, hey, this community is very concerned about this, and it's affecting their health, which is why I'm calling you. And hopefully it's not the first time you're calling them.
In terms of those silos, there's another term. There's a sort of a more optimistic term of silos, and you've heard the term cylinders of excellence, right, as opposed to silos. And so structurally, we in public health have developed organizational bodies, and that's the way I look at it. Is silo has it's a negative term. But look at it structurally that we have all these cylinders of excellence, and if we take that optimist viewpoint, saying, okay, we structure ourselves with, epidemiologists sometimes like hanging out with the epi people, and the biostats like but the idea is how do we begin to actually function with those cylinders of excellence, but at the same time begin speaking to each other, right? And that's, I think, the magic formula, because we haven't, as you mentioned, Sten mentioned the parameters of our nation, right? 4 billion dollars a year spent on health care. It's not really health care. We all know it's sick care, right? That we're spending that much. It's preventable. But what we know is we've not been really good. And part of that changing parameter has to be for this next generation, people going out in there, acknowledge that the cylinders of excellence may exist, but how do you begin talking across those cylinders with a common mission? And this is really important, because I think where we've really screwed up as a nation is, guess what? We kind of like to pay lip service like the health of our community, of our people, of our individuals is important. Do we really believe it? Is it part of our culture? And I submit to you, in my 30-plus years in public health, we're not there yet. Right? We look at other parameters. The economy of our nation. And I always kind of say that, we react to economic indicators. Oh my God, new housing starts have gone down. And we're like panicking. And ultimately a Fed comes up and says, raise those rates, lower those rates. We're reacting. Where are we when we say a community now has higher levels of diabetes than it did a year ago, right? Where's that sense of, oh my God, what are we doing about it? So I think there's two things. We have to understand the mission of public health is the health of the community, ultimately the health of the nation, and we have to realize that that health is a natural national resource. It's got to be cherished.
So this reminds me, great question, Sarah, because this will be my 22nd year teaching here at the College of Health and Human Services. And about 14 years ago, I was honored to be and I still am, the Hanlon Executive Scholar, which is bridging the theory and the practice. And we started a professional development series here about 10 years ago. And in this very room, just actually last month, we did what we call our mock interviews. We bring practitioners for our first-year students, and Sarah's gone through this in her first year. And we were short one interviewer from the community, so I had to step in to be that interviewer. And our first-year student, I'll keep her nameless, got to know her a little bit about, and we try to mock play what role, what do you want to do for your summer internship? And she began to tell her story about how she left, graduated from UCLA and came here because she wanted to work around border health. And began to talk about how she came to the school because it was closest to working and helping her family, who was asylum seeking when she was a young kid. And so that connection of deep purpose and passion for public good, we got to be reminded on the person center that each one of our students, they have a dream and a purpose and a passion. And how do we help them find their path? That engagement in that same conversation, the next day I connected her with Jewish Family Services, who's running our asylum-seeking family shelter. And she's doing her summer internship there this year. It's how do we help our students in terms of breaking down the barriers of whatever discipline it is, find their passion? Because that's what she is going to really aspire to in terms of the public good that she came for her education to do. So I think, yes, we have a lot of challenges, both in academia and the practice side, just the way you know, but we can work those through. And that's the issue, is how do we help our students get to where they're going to excel and do the type of good for our community?
Well, we certainly appreciate all you deans do to try to help us prepare to break down some of those silos. And Mr. Machione, you can bet you'll hear cylinders of excellence in my report tomorrow night for the presentation we'll be giving. I'm going to find a way. I love that. Thank you for that. And actually, my next question is for you, sir. Leading the largest integrated health and human services agency in the U.S., what have been the successes of being an integrated system, and how can San Diego be a model for others around the country?
Great question. The birth of the Health and Human Service Agency in 1997 was to deal with health inequity. And this was at the heels of two things. One, the bankruptcy of Orange County north of us in 1995, and President Clinton's passage of TANF, Temporary Aid to Needy Families, welfare reform. You'll talk about the bookends in a moment to health reform. That welfare reform was dealing with the issues of the inequity that we were having in families and poverty, particularly communities of color. And we were very siloed in the departments with social services, and some buildings we had family serving programs on the first floor and child serving programs in different departments, and they did not know that they even worked for the county, and yet they worked in the county from separate departments. It was that siloed. And so we embarked on this concept of no wrong door. Before we talked about social determinants of health, before we talked about person-centered and population health, we called it no wrong door, which is, how do we make it welcoming? That whatever door they come in, we serve the folks in need. We serve the families in need. And that began the journey in the first 10 years. And we have about 6,400 employees who work for Health and Human Services. Back then it was about 7,000. We had to move the culture. The most powerful thing you can do, as you know in being a student of strategy, and that is, how did you go from the fidelity and the 42 different logos and a different categorical funding that led to and perpetuated, if you will, the health inequities, but not by bad folks, but because of the fact that they weren't coming together. And our first 10 years was creating a common culture, an agency of one. And our past 10 years have been really focusing on taking it outside the institution to the community, which we call Live Well San Diego, knowing that no government can do it by itself, no academic institution can do it by itself. But collectively, across sectors, we can. And so that, for us, seeing the benefits of breaking down those silos inside a very large organization only allowed us to really extend that broadly to the entire community. And that is the journey we are on today.
You know, Nick's inspiring story reminds me of a colleague, David Rosenthal, who works for the West Haven VA, which is a Yale affiliate. And David came from the private sector, probably made 3 times the money he makes at the VA. But he had a vision for the veterans, who were the 10% of the veterans who were occupying 50% of the ER visits, the folks who had unstable housing, who had food insecurity, who were wrestling with substance use, mental health challenges, the classic mixture of social challenges that are quasi-medical but are just as anchored in, say, housing insecurity. And he used creative partnerships within the VA system to get the social service groups of the VA to talk to the medical services, coax folks to recognize that savings within the VA hospital system might subsidize housing costs, and did what people say is going to be impossible to do. But it was possible, and David and his colleagues pulled it off. And we estimate that today there are no homeless Connecticut veterans. Wow. And the data for that are pretty solid. And it has been a challenge because if you do have someone who's hearing voices, they may not pay their rent and they may become homeless. So it has to be an integrated effort with housing, with social services, with mental health services, substance use services, and medical services. And if you don't do it in an integrated way, the way you're trying to do it here, by integrating health and social and housing services, then it won't work. Another example that I also think is inspiring, some clever hospital administrators at the Yale New Haven Hospital saw the exact same phenomenon, having nothing to do with veterans, but having to do with people in New Haven, Connecticut. And folks were the so-called frequent flyers through the emergency room who overrepresented hospital bed stays. And when you discharge somebody with unstable housing circumstances, it was just a revolving door. It's predictable. If somebody has asthma, they go to the street. They're back with their asthma. And it's so obvious, isn't it? It's so obvious. So what they did was worked with the Columbus House, our largest homeless shelter, and they literally constructed, at the cost of the health system, they constructed a health care infrastructure with daily hospital visits and 24-hour nursing services. Now, is it optimized housing? No. But is it a place where a homeless person can leave the hospital and get proper medical care and maximize the chances that as the social service agencies are trying to help them with permanent housing, they can avoid this revolving door. So in this case, the more resourced part of the health system subsidized a functional housing solution and substantially benefited a group of chronically ill homeless individuals. So these examples of where we can get out of our silos and come up with integrated solutions can be really quite inspiring and worth replicating.
All right. So our next question actually comes from Dr. Walsh-Buhai here in the audience. Thank you, sir, for this. The federal government often funds projects by content such as HIV prevention, STD services, etc. But those content areas are often related. How have you, as deans, navigated funding streams to enhance cross-silo collaboration? And this is open to anyone.
Well, I've been on a panel, the Scientific Technical Advisory Group of the World Health Organization's Reproductive Health and Research Division. Mm-hmm. And on the global side, they're trying to do one simple thing, which is to integrate the substantial resources being put into HIV prevention and care for adolescents with other reproductive health and sexual rights investments to try to mainstream these segregated investments so that girls and young women can not only prevent HIV, but also control fertility, also prevent STDs, also stay in school. And it has been a very heavy lift, very heavy lift. We've had meetings all around the world. We've been producing reports, and it's we're so addicted to vertical programs. We're so addicted to the reliability of statistics that we're putting so and so many people on HIV therapy. We've tested so many people for HIV. We forget that, say, the mother-to-child transmission of HIV, can't you integrate prevention of syphilis and can't you integrate prevention of hepatitis B at the same time with two simple tests and some much cheaper interventions than are represented by antiretroviral therapy? So it is a global pathology in our country, overseas, that we like vertical programs. We like the simplicity, we like the technical consistency, we like the ability to report on these defined sort of polio, endpoints. and not so good at the comprehensive provision of community-based primary care.
I think to a large extent, you know, and this is speaking from a person who served in the federal government for 28 years, is the system is set up for that vertical system, right? I mean, the way we look at NIH and all its institutes and centers and all that, you know, you got the grant monies that's given to you, and you say, well, you're going to do work in my line, right? And so the system is set up for what? For a vertical process to be submitted and ultimately win. And we all feel good, oh my God, look at the grant money I got, realizing that it's really not penetrating, nor is it necessarily doing this interdisciplinary approach. I think it's high time that we influence those funding agencies, right? I mean, you know, you and I and, you know, many of us have spent time within that federal family. We kind of know it. And we have to influence changes within that realm. We're seeing a little bit of this, right? We see funding agencies now coming up and basically saying, okay, fine, it's in our line of work, but what we want, right, the winners will get extra points if you do, and now fill in the blank, partnerships, if you bring in the community activities, right? If you don't just hold on to it yourself. Now, unfortunately, we still live in a world where resources are limited. We're all fighting with each other for those same dollars, right? We're friends here now, but tomorrow, if we're submitting grants, we're kind of, you know, so that's the reality, is that when you have a resource-limited environment, we're still fighting. But ultimately, there's got to be more of this changing of the funding agencies to begin looking at what really works. And they need our input. I think the academic input needs to sort of come back to them saying, it ain't as simple as you getting dollars from the budget and then sending it on and that everybody feels good. We really want to do things that are effective and efficient.
Yeah, and I think, and the reason we all hesitate is there's not a great answer to that very good question. But I think, you know, thinking back on my career, where we've been able to use a vertical funding source to do something greater is when we have a partnership with something like a really strong county health department that we have a long-standing relationship with, where we've worked in multiple different arenas. And so you can call your county partner and say, okay, here's the opportunity. Help me fit this in with your larger effort, right? And I think the best example for us in Florida was our Healthy Start program, where the original George Bush Sr. Healthy Start money came to the College of Public Health for the county. And we maintained that effort for many, many years. They finally split off and formed their own nonprofit corporation, but we continue to work in partnership with them. And that's a wonderful, grounded, very comprehensive, community-based effort to improve pregnancy outcomes. And so when grant funding becomes available, whether it's from the federal government or the state or even other foundations, we can work with them to make sure it fits into something larger. But that only works when you have those long-standing relationships, because otherwise it's exactly what everyone says. And we all, whether we like it or not, and I was going to challenge you, but I think you're right. The system creates it, but we're right there at the trough, you know? We're right there, and we're willing to compromise even our own principles to get this precious money. It's a real challenge.
Just to add to a point Donna made, and I think it's spot on in terms of the partnership with your local public health. So we're retail. I thought you were going to get to that, right? So federal government is wholesale, state is distribution center in many cases. In California, at least, local public health is retail. And there's a blessing and a curse in that, because we have all the color money categorical requirements, but we also have the opportunity to bring things together. So more recently, here's a recent development, is our Getting to Zero aim with HIV. We're now working with our local liver association to, well, why not just Getting to Zero and do a quadruple aim for TB, HIV, hepatitis C, and even gonorrhea, and that's an issue for us in San Diego. And it's blending the funding. The hardship we have is you have to have a good partner in the school of public health, which we do have here. But you need to be able to test that to say, how would this look like in putting this together? And in terms of public health and health departments, sometimes it's a lonely place. Because yes, we work with a lot of folks in the community, but you're not incentivized in blending funding. It's much more challenging in blending funding because you have to deal with your procurement departments and everything else that comes with that that make it very challenging, right? But I think if you have a willing partner coming together, it does motivate more and more health departments, I think, to bring and leverage those funds that we do get that in many cases, not all, have the ability to bring those together at the local level.
So the other thing I was going to, and it goes on, I want to dovetail to something that Boris mentioned, and that is, in particularly, I think, for you all as public health leaders of the future, it's about advocacy. And I really think it's important that you all are speaking up and you are talking with your elected officials and you are talking with people at the federal agencies about what your struggles are. Because I will tell you, when I was at CDC, and I was there for over 25 years, there were so many times as I was crafting that new funding opportunity announcement, I would hear the voices of some of those community members who said, keep A, B, and C in mind. Or when I was talking with my fellow division director, I would say, we got to remember A, B, and C. And so I think it's really important as future public health leaders that you're not silent and that you are advocating and you are very vocal. There were many times I had really tough conversations with community members, really pushed me in a very different way from it. And I think doing that is really important, and that's a really important part of what public health is advocating and advocating for change.
Wayne, I wonder, could you comment on UIC and its relationship with the Chicago Health Department? Because you're from the biggest urban area of any of us on the panel, and I'd be very curious because it's such a vast enterprise. How does your school engage? Yeah,
so we've got, and it's really been, I've been at UIC for 2 years, and it's really been a learning environment for me. So I think there are a couple of things. I think one is we have a really deep relationship with the Chicago Department, with both, I would say, Chicago Department of Public Health and also Cook County Department of Health as well. And I think that's because of a couple of things. Number one, a number of our faculty worked at the Chicago Department of Public Health or Cook County. And so there's sort of those really unique relationships that have developed because sort of we've come from each of the different health departments. But we've also created what we call an academic health department as well. So a number of faculty from the health department teach in our courses, and we go back and forth. There's a lot of co-grants that are done as well. So I mean, it's a lot of the relationships that are happening here in San Diego as well as part of this. But we've got a really deep and robust relationship. The commissioner, and I sort of call each other periodically, and I think that happens with all of with all of the deans here. We've got a really deep and robust relationship because we realize sort of the value. We spend, a lot of our students also sort of go and do their practicum experiences, integrated learning experiences in the health department as well. So there's a huge amount of back and forth that I think creates a really enriching learning environment across the two. And I think that's true with all of the schools here on the table, and that's really sort of very exciting.
Mm-hmm. Anyone else? All right. Okay. Well, that is all the questions we had submitted online. So I'd like to open it up to the folks in the room. Would anyone like to pose a question to our panelists?
I'll start this off. So those of you, of course, and we've been in federal government and now academia, which one's worse in terms of silos, and where will our students struggle more in being able to break those barriers for advancing health equity?
Well, I was in the federal government for almost 6 years, and I was about as siloed as you can get because I was in a branch that was the vaccine trials and epidemiology branch within the Division of AIDS. within the National Institute of Allergy and Infectious Diseases. And I think my colleagues at CDC almost had a stroke when I showed up there 3 months into my tenure, and I went down to share with the counterpart division at the CDC what we were doing at NIAID, because my predecessor had never done that. So here we were the division of AIDS, they were the division of HIV/AIDS. I was an epidemiologist. Most of my counterparts were actually at CDC as epidemiologists, and they just weren't talking to each other. So not only were we siloed, but then the agencies were siloed, so double trouble. And it's a little known fact, but the Office of AIDS Research in the Office of the Director at NIH is there really in part to police the institutes to make sure they don't get out of their AIDS lane. So if you say, well, we're going to invest in HIV, but since sexually transmitted infections are related to HIV, in fact, HIV is a sexually transmitted infection, we're going to fund this sexually transmitted infection grant. No. If it's not going to be nested within the context of HIV, you cannot use the AIDS money for an STDI grant. Similarly for tuberculosis, which we know is strongly allied to HIV in the highest incidence nations where those two coexist. Only if you have a specific HIV focus will the TB grant be permissible within the HIV. So it's very much what Boris said a minute ago. We've done it to ourselves. We've created these extreme interest groups so that, if you're going to fund Alzheimer's research, you can't fund something else in the neurological diseases arena, even if it might be an important thing to do and might even eventually help in Alzheimer's research. If you have advocacy for one kind of cancer, you can't necessarily divert that money for another kind. So we've become an environment where the people who scream the loudest and have the strongest lobbyists have the greatest resources. And if we could break down some of these silos, I've often thought that the NIH, the CDC, should be completely reorganized. And rather than focusing on disease groups, they should be focusing on cross-cutting challenges. So we focus on diabetes, and that's in one institute. We focus on heart disease, that's in another. We focus on cancer, that's in another. But there is no Institute of Dietary Health and exercise. So the battle to have healthy diets and the struggle to avoid sedentary lifestyles are not where the focus is. It's simply at the end of the disaster that abundant attention is being paid. Now, I'm not trying to insult the institutes. They obviously fund some prevention research as well. But let's be frank. It's much more compelling to and sort of more easily funded to have a molecular line towards a vaccine or a therapy than it is a community intervention for getting kids out to play, for restoring recess and gym class to undercapacitated schools, to work on food deserts and the availability of salty, sugary, cheap foods, the relatively unavailable healthy foods that may even cost more. So we let these issues fester, and meanwhile we satisfy ourselves with the sort of scientific satisfaction of the purity of the research within our silos.
Your question, what was worse, right? Federal government or academia? I don't think one is worse or better. They're different. And I kind of think back through, we do create our own silos, and sometimes it's based upon, our interest areas or the agency's interest areas. So I had 16 years at CDC. all those years spent with the National Institute for Occupational Safety and Health. We were the ugly stepchild of CDC. I think most of us will admit it. We're further away. Who deals with occupational issues? We're unified, however, with that idea of a spirit that we were doing something that nobody else was doing. Oh, sure, there's the Department of Labor, there's OSHA, but there was a good partnership there on a specific mission. I then transitioned to the FDA, working in counterterrorism and emerging threats. Realized that that's a whole nother world I had to get used to, and learned the simple little things, that a hot dog by itself is regulated and supervised by the Department of Agriculture, but you put the damn hot dog into a bun, that becomes FDA, right, if it's sold that way. So, you know, that didn't make sense in terms of the foods thing, and that's a whole mess in terms of food security. But in essence is you begin learning on a certain area that is counterterrorism, emerging threats, who your partners are. I would say that the fruition of my career in terms of partnership was the 5 years, or were the 5 years spent in the Office of the Surgeon General. And the question is why? Well, guess what? The Surgeon General's office has no budget and has single-digit to sometimes teen numbers of staff. We had nothing. We were supposed to have an image like we had something, and the only way we accomplished any of our work was through partnerships, right? And the beauty is when you're sort of have nothing and you have to do something, then that's where things start breaking down, right? In terms of actually people saying, okay, well, we got to work together. The other thing that I had in terms of my career path was 27 of my 28 years in the federal government, the federal system. And I'm not talking about the federal prison system. I'm saying about the, being in what was in uniform, right, in the U.S. Public Health Service Commission Corps. And that's an interesting model because where did we best function? We were dispersed all over, 11 different professional categories, right? Doctors, dentists, nurses, pharmacists, social workers, health services officers, veterinarians, therapists, right? 11 different categories. And the way we worked together was when we had a crisis and we needed to do something. So you look at World Trade Center, you look at anthrax, you look at Hurricane Katrina, you look at the pandemic of 2009, you look at Ebola. And in that circumstance, not that we started working together early on, some of them were disasters beyond just a natural disaster, but ultimately that thing functioned when you had a common mission. And I agree with you. If we sort of realigned our missions to be much more huggable, right, and group activities, group dynamics, then we would go much further than what we have now.
So I think the best thing to do is find an enlightened local health department or an enlightened state health department. To me, that's where the action really is. You guys are not going to change the organizational structure of NIH. I mean, that goes back to Congress and the special interest. I mean, it's maybe little bits here and there. When you have enlightened leaders, they'll do things. But honestly, find an enlightened agency because that's where the action is. And you can do things. I mean, I remember doing things at a state health department because we had great leaders and you would blend things and make sure it was audit proof and hide stuff when the inspectors came, but because you were driven by the mission, right? You were driven by the mission, and crises brought people together. And academia is the same way. Find an enlightened institution. I think you see some at the table, and I think it can be fine. But it's really about you and what you care about and your fortitude to do this work and to forge new pathways wherever you are. And you'll make them better wherever you are.
I guess I've been wrestling with I think they're just very different. I will say I spent 25 years in the Chronic Disease Center at CDC, running 3 different groups. 2 of the groups, one was a division of population health, which was very cross-cutting, and the other was the division of adult and community health, which was also really focused on funding large cities across the country. And I will say that through those initiatives, we were able to do a lot of work. For example, under the Obama administration, we had communities putting prevention to work, which was $400 million. We went to a number of cities, including, I think, San Diego, as part of that. What was focused on tobacco, nutrition, and physical activity, but really sort of bringing those activities very much focused on policy, systems, and environmental change. But really, we were able to leverage a huge amount of federal funding that really mobilized and I think really helped in a number of cities. For example, I know in the city of Chicago, really put in place some really comprehensive, unique work around addressing root causes, everything from what happened in the workplace to what's happening in schools, communities, bike sharing, all sorts of really exciting work. So I bring it up just because I do think that, and I agree with Donna about sort of looking at what you can do at local and state government, but I do think there is also an opportunity when you have the right administration, key right administration. I think you can do, I think even on the federal side, there are opportunities to do some really amazing work.
Right. Any questions from the room? Yes.
Thank you for coming, and I really enjoyed. You know how I'm the faculty here in School of Public Health. I'm in the Environment Health Division, but my training is really, really kind of a basic science. I've been thinking about. I mean, public health is actually we're doing a lot better than other disciplines. My understanding in terms of breaking the silos and working together, collaboration. I was thinking about, sometimes I met the students, undergraduate who study chemistry, who study biology, they are interested in coming to the public health, for master's degree or PhD, and then they were telling me that how difficult, their study is, in terms of the chemistry courses, sometimes like, they want to learn a lot, but and then, my point of view is that the curriculum and then the teaching has not changed like for decades, It's like the textbook is like 30 years old. I mean, like, so something like whether the students are actually become like passionate about it, like what they learn, and then they actually implement it, to what they're going to do in future. They keep like more like putting down themselves, like, oh my God, this is so difficult, I can't really survive it, But actually, when I see them, they're very smart, My concern is that, I mean, public health will be evolving. I see that we're evolving much better than other disciplines, But we kind of want to help the other disciplines. I think that we can, train a good students with the strong science background and then come into our discipline and do better, When I see them, like, for example, I tell them, like, my God, what you're learning at this textbook, one page, one reaction is actually someone's whole PhD thesis that you're learning it, and 100 pages one semester. What I was thinking about myself, also chemistry I was studying, it's still, it's like, they're like memorizing doesn't really learn that why they are doing it, for problem solving in the future, So I was just kind of thinking about that a lot these days, because we want to recruit the students who have a strong science background, but and then they really, do not enjoy or they do not get passionate about what they're doing, and then they don't know, how they can actually be much valuable when they come to the public health. I just want to, ask your opinions about, your interaction with the other colleges, the other colleges' curriculums, stuff like that.
Well, part of it, and this is always very difficult because it becomes very personal to some extent, right, for that specific student, is really, the key word really is what the passion of that student is, right? The beauty of public health, as you know, is taking that science background and at all sorts of different levels, right? There can be a minimal, there can be a maximal of that. But ultimately, it's a sense is that we touch people with that science, right? There's, for the most part, there's this applicability to doing good. And as I like to always tout with our students at University of Maryland, this is a bold and noble profession, right? It's bold and noble. It's difficult. It needs to be filled with an air of optimism, but you can't force it, right? I mean, that's the other thing that, I'm sure all of us see students who think they want to do public health and then ultimately never develop that passion, never develop that approach of wanting to change the world, right? Some students are more comfortable with that chemical formula. And I'm not sure if we can turn that pure scientist, the bench scientist, into a public health person. It's arguable, right? I would like to think that the more we show them of the good that they do, the more we can sort of open up their eyes. But, it is a struggle, I think, for us to be able to figure out who fits into this. Right now, my fear is that I have a huge undergraduate program, and the question is, what am I doing for the good of society by producing so many undergraduates in this field? Right now, my attitude is I'm going to change the world, because no matter what they end up doing, they've learned in those 4 years something about society, about people, about health and wellness. And if they go to law school, if they get a job at a health club, if they do something, they're going to come in with that. And maybe that's the parameter that will change the world. But
Well, and I think relatedly, there's some feeling, I don't want to say evidence, but that the rapid growth in undergraduate public health programs across the country was a result of national discussions around undergraduate education at all, about trying to make it more meaningful, more impactful, more linked to societal needs and goods, and helping students find pathways to fulfilling careers, not just jobs. And that public health is such a great example. Like, you can have public health examples in English classes, in math classes, in chemistry classes, and that as people were adapting to AAC&U's new LEAP framework, that public health became a framework that enabled universities to really embrace that new model of undergraduate learning writ large. I don't know if that's true or not, but it makes some intuitive sense, and I had the pleasure of going to a lot of those meetings over many years when the Association of Schools and Programs of Public Health was leading its Framing the Future initiative and learning a lot about undergraduate education. And to me, it gets back to something I said earlier, where if you can create those partnerships within the academic environment, does everything need to be 3 credits? Does everything need to be 3 credits plus a lab? Well, what if it's 2 credits of basic chemistry and then 1 credit of applied chemistry to human health? What if it's 3 credits and then 1 credit where they're actually out in the community doing some, we get ourselves locked into these. And I think if you can create, your dean you can create those related. We've done more and more every year. We're doing it at our university. For a lot of reasons that I won't bore you with. But I think there are so many opportunities to, as Boris said, help those students that really do have that passion to find the outlet, to find the root, to say, yeah, it's not chemistry light, you still need to know, but it's how you even think about, why am I doing chemistry at all? I mean, maybe the first credit should be, what does chemistry mean in your life? So that when you're then doing the chemical, I know nothing about chemistry, I can barely spell it, but whatever it is you do, you're doing it in a context of, I can see where this has meaning for me. So I think there's a lot of room for much stronger dialogue and much more consistent conversation around some of these opportunities.
And I agree. I think the applicability issue is what's knocking most discipline. And when I have conversation across the California State University system with the chairs, is how do we take what we're doing with our undergraduate public health students and impact the entire campus, not just have a course on personal health and wellness, which means very little to most people, which has been the way public health has been a GE in campuses, to what is public health and how does it impact your actual field that you're studying. How do those two relate into a world that changes? I think if we can do that and create people who have a bigger understanding of it, then it impacts the work they do at an agency, because they come in, even if they're a social worker or they're whatever they are, they have an understanding of how that discipline can then turn around and have human health implication, every societal implication. And I think that's what this whole panel is about, is how do we get people to think outside of that box of their discipline to really impact health equity, to really change the world that we hope can all change.
And to get past the police that are standing at the door.
Yes.
I call it the troll at the
Right.
bridge that you have to get by. You know, but if you can get around the troll, boy, there's a lot going on out there.
And I always tell our students how lucky we are to be in San Diego, honestly, because we have a lot more opportunities to do that work here. There's a culture, start with the agency, but also more broadly in San Diego as a community. People want to see big ideas, big changes, and that spreads across the state. California always thinks of, they call themselves the state of the future, right? So it's always starting to think about what we can do differently for a long way. Yeah, so.
And may I just say, as a student, I feel like we are fostering that here, that overhead view, if you will, through the CAMI program and being an accredited program. I certainly feel like I've gained that confidence and that exposure to see it at a more strategic level, if you will. And then also in the partnership that we have with Mr. Maschione's organization as well. I know a lot of our students spend time over there, and we do gain that perspective and get to see how the different facets of your organization work together to achieve the health outcomes we would like to see. And obviously, it's still in progress, but we certainly appreciate that. So I know I can't speak for all students, but I've been fortunate enough to experience at that level, and I absolutely see it working. And I know there's a lot of hope among the students, and it's, moving toward that value-based and the preventive care and all the things that we would like to see happening, right? And addressing those social determinants of health. I feel like those conversations are happening amongst the students, and we don't always see things in silos. So, but I love the question. That was a really good question. So, any other questions from the room?
Thank you for traveling such distances and being here. And I know there's going to be many that are going to benefit from the streaming. This is a really important topic area for us to be confronting. So my question, and I'm an epi here at the School of Public Health. So my question has to do with philanthropic support. Because if you look over time, the philanthropic spending for research and for public health initiatives has really, gone up. And so I have sort of a two-part question. One part is, in your opinion, how well targeted are those initiatives, and how, and also in terms of efficiency of outcomes. My second part has to do with the county. Because in my infectious disease epi class, I bring in, different professionals that are like boots on the ground. And so boots on the ground for STIs is Dr. Winston Tillman, who's phenomenal, running the whole STI division. And what's interesting for me is working internationally, as Dr. Vermund does with PEPFAR, I see all kinds of out-of-the-box approaches to trying to change behavior. And funding to do some really interesting things. And then Dr. Tillman comes to the class, and here we have in the U.S., the STI rates are just going, like this. And he's very creative, he has creative staff, but the resources are not there. So I guess the second part of it is should some of this philanthropic, because it seems like most of it's going globally outside of the U.S., are there ways to draw that into our own health crises?
The imaginations of some very wealthy individuals has been captured by the field of public health in recent years. Mayor Bloomberg has given $2.6 billion to his alma mater at Johns Hopkins, at least $600 million of which went to the School of Public Health, which is now named after him. Michael Milken at George Washington, the Dornsife family at Drexel, the Chan family at Harvard. It goes on and on. The Rollins Foundation is building yet another building for Emory. So in reality, there are many persons of substantial means whose imaginations have been captured by the field of public health. So I think that's a positive. One can only think about the Bill and Melinda Gates Foundation writ large as the largest foundation in the world by far, who that foundation has a focus on American education, but his prominent focus is on public health. So I do think that's an optimistic sign that people do appreciate the value of prevention. I think one challenge in our discipline is if we do our jobs properly, nobody hears about us. There is no fire to fight because public health has been watching out for it behind the scenes. We don't have the pool of grateful patients as the medical schools do, as in the philanthropy space. So it's up to us to tell our stories and to continue to alert folks who are looking to have the greatest impact, that perhaps in prevention one can have the greatest impact.
I think it goes back to what I think Boris said earlier, that we really haven't embraced this notion as a nation and as a culture that health matters and is important. It needs to be addressed with the same level of attention we give to other aspects of our society. That's part of the challenge. And I think I've had the experience where, especially something that is perceived as a role of the state writ large, you know, why would a private contributor give to something that they believe should be taken? I pay taxes for that. Not good understanding of how this works. And then it's back to what we were saying before. You have needs. Nick and every county health officer and state, they know what the needs are, but the funding doesn't come that way, and so you're forever having to beg and borrow and steal and patch things together. It's a challenge. So I think going through the academic route seems to be the more profitable, the more productive. I guess I shouldn't say profitable, but and to try to then support a broad-based approach to prevention and the health of populations and communities, because we're not getting it directly into the community yet. And I think it's part of it is just we just don't share that spirit.
Think another sort of aspect to this is how do we sort of celebrate our accomplishments? You know, we've been, many of us are outspoken, but in general, public health is a meek and humble profession. We do our jobs, we go out there, we know what we're doing, but we're not really good at packaging and selling it to the outside world. Right? There's, you know, the old saying, and the other many people have coined it, but, you know, when on the world of prevention, right? When prevention works, nothing happens. Now, that's a double entendre there, right? Because it's kind of a cool way of putting it, but in essence is as opposed to a celebration when prevention works, right? We should have the release of 1,000 virgin doves and fireworks going off when we have those parameters out there saying, look what worked, right? Going back to my previous stories of the Public Health Service Commission Corps, our junior officers every year will come up with a T-shirt that talks about how no one knows about what they're doing. And one of my favorite ones a few years ago was, you know, on the back of the T-shirt, front said U.S. Public Health Service, back said, if smallpox isn't currently ravaging your community, feel free to thank us, right? But when it goes to the philanthropic world, philanthropists want to know what good is happening out there. And unless we're packaging that, this is marketing to some extent.
Yeah.
Selling it, that's what it is. It's selling concepts and being proud of our accomplishments and honest about our failures, right? Then we're not really taking advantage of a 21st century world. I think we have to be really better at saying, look how we've changed the world already, and look what we're doing. You know, in light of that thing I mentioned about the 10 great accomplishments from CDC MMWR of 1999 of the 20th century, I like to sell it right now as right now, here in this room. There's a small gathering, there's a gathering on the web, there's people listening to this. But guess what? By this work and this discussion, we're now compiling the 10 great accomplishments of the 21st century. I won't be around to see it when it's published in 2099, but others will. But every single step of the way, every day, we're compiling that list of 10. And we're getting better at something. And we have to understand that that's where we're heading.
Well, I think that's a perfect culmination to the discussion we've been having, in that it starts in these discussions, right, in breaking down those silos and then leading hopefully to some of those accomplishments that we will see and coming from some of the graduates that will come out of all the universities that are represented here today. So,
So, I'll add, it's an excellent point, because I was thinking it is another driver of health inequity, right? Disparity and opportunity. Because I look at my agency, the STI is not the sexy place to go invest from philanthropy, never mind from federal or state. And so, we have a $2.2 billion budget for health and human services, and we have to balance all the needs. And so it's, if you do some hot spotting, automatically it gets lots of attention and you get some funding, et cetera. And what we're talking about, much we're doing, is kind of more kindling spotting, right? Going far upstream before you start seeing the fire and the problems. And that's not as desirable. And so it is how we reframe. And it's a challenge within our budget deliberations of how we do it in the county. It's frankly a challenge in Sacramento, as it is a challenge in DC. And we've been at, for decades. I mean, this is not something new. So how do we augment that? I think that's how we leverage existing resources. I get back to the partnerships, because it's not going to be enough within public health or in our school, but how do we bring other partners? Our fully qualified health centers, is another great area of partners that have been coming to the space. And I think that's the part where, we've kind of cobbled that together, not enough, but kind of cobbled that together. We have a catastrophic event, hepatitis A, you get it. All the resources pour in, right? Hot spotting. And so, and we're trying to avoid hot spotting. We're trying to do kindling spotting, right? And there lies the challenge, right, for us in public health.
all right. Well, my apologies, folks. As much as we'd like to hold these brilliant minds hostage, I know we need to let them get back to doing the good work that they are so renowned for. So that is all the time we have. I want to say thank you to the faculty and students and those who joined us via live stream tonight. I would also like to extend our sincere thanks to the Graduate Student Council, to Dr. Madanat, to the School of Public Health, and to our panel members. Everyone, please join me in a round of applause for our distinguished guests. Thank you, everyone.
That's good. Great. Thank you.